supine, the examiner holds the patient's legs or places a stool under them for support such that the patient's hips and knees are flexed approximately 90 degrees. The patient must relax their lower extremity muscles. With a positive sign, the tibia sags posteriorly compared with the uninvolved knee, similar to the sag sign. The patient sits on the edge of the table with their legs supported in hips and 90 degrees flexion and hands behind their back. The patient then slumps into full thoracic and lumbar flexion. The patient then flexes their cervical spine maximally while the examiner maintains overpressure. The patient then actively extends their knee while the examiner dorsiflexes the patient's foot. A positive sign is reproduction of the patient's symptoms in their back as well as radicular symptoms into one or both of their lower extremities. With the patient supine, the examiner passively raises the patient's leg to the point that radicular symptoms are reproduced. The leg is then lowered slowly to the point where the pain is relieved. The examiner then dorsiflexes the patient's foot. A positive sign is reproduction of the patient's radicular pain when the leg is between 30 and 70 degrees. The pain is reproduced again when the foot is passively dorsiflexed. Pain reproduced in the back alone is not a positive finding. With the patient supine, the examiner grasps the patient's heel with one hand and places the other hand on the knee, palpating the medial and lateral joint line. The examiner then applies full internal rotation while taking the knee from full flexion toward extension. This is repeated with the tibia and external rotation as well. A positive sign includes palpable click or pop emanating from the joint line and pain along the joint line. With the patient prone, the examiner hyperflexes the patient's knee, forcing the patient's heel toward their buttock. This position is held 45 to 60 seconds. A positive sign is reproduction of the patient's radicular symptoms into one or both legs. When the patient's knees are returned to 90 degrees flexion, the patient exhibits decreased muscle stretch reflexes and muscle weakness. With the patient supine and the knee flexed 90 degrees and hip flexed, the examiner applies pressure with their thumb over the iliotibial band just proximal to the lateral femoral epicondyle. The patient then actively extends their knee. With a positive sign, exquisite pain is elicited over the distal iliotibial band at the point of pressure approximately 30 degrees before full knee extension. With the patient supine, the examiner first performs the Wilson-Barstow maneuver to establish symmetry before initiating the test procedure. The examiner performs gross leg length assessment by comparing the medial malleoli position. Finding of a shorter leg suggests a possible posteriorly rotated innominate. While the therapist holds the medial border of the medial malleoli with their thumbs, the patient is asked to come to a long sitting position and leg length is reassessed. Any apparent lengthening of the short leg implies the presence of sacroiliac joint dysfunction and a posteriorly rotated innominate. An estimated 2.5 centimeters minimum difference should be used to establish a positive finding. The patient is supine and maintains their back flat on the table. The patient then rests one leg off the end of the table with the knee extended while flexing the other hip by pulling the knee to the chest using their hands. This position is then held. With a positive sign, the extended lower extremity flexes slightly at the hip and knee, raising the lower extremity from the table. The patient is sitting with their knees flexed and hanging over the edge of the exam table. The examiner places a quick stretch on the gastrocnemius muscle by abruptly moving the patient's foot upward into dorsiflexion. Clonus is the rapid oscillation of contraction and relaxation occurring in response to the quick stretch. This results in reverberating dorsiflexion to plantar flexion motion of the ankle. There may be several beats, or in some cases, the clonus will not cease until the stretch is released when the examiner passively plantar flexes the patient's ankle. The patient is supine and holds their thigh so the hip is in 90 degrees flexion. The patient then actively extends their knee while the examiner uses a goniometer to measure the angle formed by the femur and tibia. The examiner should compare the knee angle to the opposite knee. Although reported as a useful, valid alternative to the straight leg raise test in the literature, little to no normative data exists for adults. With the patient supine, the examiner flexes the patient's hip to 90 degrees and then applies an axial load and circumducts the patient's hip. In a positive sign, this maneuver reproduces exquisite pain and crepitus in the hip or groin. The patient sits on the edge of the exam table, and the examiner places one arm under the patient's thigh to act as a fulcrum. With the opposite hand, the examiner applies pressure to the patient's distal thigh just above the knee, introducing a bending force to the femur. With a positive sign, there is a significant reproduction of the patient's symptoms of deep aching pain in their groin or thigh, and the patient demonstrates apprehension. With the patient supine, the examiner grasps both of the patient's great toes and lifts their feet from the table. The patient should be told to relax their quadriceps muscles. With a positive sign, the patient's involved knee assumes a position of slight recurvatum and the tibia externally rotates. The involved knee will appear to have tibial vera. With the patient supine, the examiner passively flexes the patient's neck by pulling their head toward their chest. In the presence of a positive sign, there would be reproduction of the symptoms of the back, and the patient would involuntarily flex their knees and hips to relieve the back pain. The patient stands and extends their spine while the examiner stands behind the patient to control movement and apply overpressure and extension while the patient laterally flexes and rotates to the side of pain. With a positive sign, symptoms are reproduced down the lower extremity to the test side. The patient is supine, and the examiner raises the patient's leg that is opposite of the side of reported radicular symptoms. A positive sign is reproduction of the radicular pain into the contralateral leg or hip upon raising the asymptomatic leg. Pain reproduced in the back alone is not a positive finding. The patient is sitting with both knees flexed 90 degrees over the edge of the table. The examiner passively extends one knee. With a positive sign, the patient extends their trunk to relieve tension or falls backward and supports the body with their hands. The patient can be sitting or supine. The examiner runs a pointed object such as the handle end of the reflex hammer along the plantar aspect of the patient's foot and across the metatarsal heads from lateral to medial. With a positive sign, the patient involuntarily extends their big toe and abducts or splays the other toes. With the patient supine, the examiner places their hands under the patient's heels. The patient is then asked to perform an active straight leg raise one leg at a time. A positive sign is present when the patient fails to lift the leg or the examiner does not feel pressure from the patient pushing off under the opposite heel. With the patient supine, the examiner presses down and out on the patient's anterior superior iliac spine simultaneously. A positive sign results in increased pain or reproduction of the patient's symptoms unilaterally in either the gluteal or posterior thigh region. Have the patient use one finger to point to the side of pain when they complain of pain in the lumbosacral region. With a positive sign, the patient localizes the pain with one finger to an area immediately infromedial to the posterior superior iliac spine within 1 centimeter, and the patient consistently points to the same area over 2 trials. With the patient standing, the examiner palpates the patient's posterior superior iliac spines with their thumbs while the patient bends forward to touch the floor. With a positive sign, there is superior movement of one of the posterior superior iliac spines compared to the other. A positive test is purported to indicate limited movement of the ilium on the sacrum, displaying limited sacroiliac joint motion on the side of the superior posterior superior iliac spine. An estimated 2.5 centimeter minimum difference should be used to establish a positive finding. With the patient sitting on a level surface, the examiner palpates the patient's posterior superior iliac spines. With a positive sign, one posterior superior iliac spine is lower compared to the opposite side. This suggests that the ilium is rotated posteriorly on the sacrum, while the opposite ilium might be anteriorly rotated. An estimated 2.5 centimeter difference should be used to establish a positive finding. With the patient supine, the examiner first performs the Wilson-Barstow maneuver to establish symmetry. The examiner then measures from the patient's anterior superior iliac spine to the tip of the medial malleolus. A difference in measurement greater than 1 to 1.5 centimeters is considered significant. With the patient supine, the examiner first performs the Wilson-Barstow maneuver to establish symmetry. The examiner then measures the distance from the tip of the xiphoid process or umbilicus to the tip of the medial malleolus. A difference in measurement greater than 1 to 1.5 centimeters is considered significant. The patient is supine and maintains their back flat on the table. The patient then rests one leg off the end of the table with knee relaxed in a flexed position while flexing the other hip by pulling the knee to the chest using their hands. This position is then held. In a positive sign, the flexed knee extends and is pulled up from the table. The patient is prone, and the examiner passively flexes the patient's knee. With a positive test, the hip on the same side spontaneously flexes. With the patient side lying on their non-affected side and the non-affected lower extremity flexed at the hip and knee to obliterate any lumbar lordosis, the affected side knee is held in 90 degrees flexion while the examiner stabilizes the patient's pelvis. The examiner passively abducts and pulls the patient's thigh and hip posteriorly until the thigh is in line with the body and allows the leg to drop toward the table. In a positive sign, the lower extremity remains abducted and will not fall toward the table. With the patient supine and their back flat, the examiner performs a straight leg raise test. The straight leg being raised should raise at least 80 degrees from the table. The patient is supine, and the examiner performs a straight leg raising test. If a limitation exists on the straight leg raising test, then the examiner flexes the patient's knee to see if more hip flexion can occur. In a positive sign, there is reproduction of the radicular type pain even when the knee is flexed. With the patient supine and lower extremities extended and relaxed, the examiner grasps and stabilizes the test leg and strikes the patient's heel with the palm of their hand. This imparts a quick axial load to the lower extremity. A positive sign elicits exquisite hip or groin pain. With the patient supine, the examiner places the patient's foot of the test lower extremity on the opposite knee. The test extremity is then lowered in abduction toward the table. A positive sign elicits pain, muscle spasm, or there is limited motion. Positive findings with overpressure may indicate sacroiliac joint dysfunction. The patient stands and then hops up and down on the involved lower extremity. A positive sign is significant reproduction of the patient's symptoms of deep aching pain in their groin or thigh. With the patient supine, the examiner applies combined hip flexion, external rotation, and abduction, then moves the patient's hip into extension with internal rotation and adduction. A positive sign involves reproduction of the patient's symptoms of sharp, catching pain deep in the groin. With the patient supine, the examiner applies passive flexion, internal rotation, and a posterior axial load. A positive sign involves reproduction of the patient's symptoms of sharp, catching pain deep in the groin. The patient stands with single limb support. With a positive sign, the patient's pelvis drops on the opposite side, the unaffected side drops, and the affected side shifts laterally. The patient is prone with their knee flexed 90 degrees. The examiner rotates the patient's hip medially and laterally until the greater trochanter is parallel with the table or reaches the limit of motion if the trochanter is unable to reach the parallel position. The degree of antitorsion is then estimated based on the angle of the lower extremity to vertical. Antitorsion greater than 20 degrees is considered excessive. The patient is prone. The examiner draws an imaginary line from the ischial tuberosity to the anterior superior iliac spine on the same side. The examiner then palpates the greater trochanter. The tip of the trochanter should lie on or below this imaginary line. With a positive sign, the greater trochanter can be palpated well above this line. The patient is supine. The examiner draws an imaginary line from the anterior superior iliac spine to the table. A secondary imaginary line is then drawn through the greater trochanter parallel to the table and perpendicular to the first line. The examiner then measures the distance from the secondary line to the table. A positive sign is present when the distance of the secondary line from the table is greater on the involved side compared to the uninvolved side. With the patient supine, the examiner grasps the patient's foot with one hand and just distal to the knee with the other hand and applies a valgus stress with internal rotation of the tibia and extends the knee from 60 degrees flexion to 0 degrees extension. With a positive sign, there's a sudden subluxation or jerk of the tibial plateau at 20 to 30 degrees of knee flexion. With the patient supine, the examiner holds the tibia with both hands and fully flexes the patient's knee. The examiner then allows the knee to passively extend. Positive sign is failure of the knee to reach full extension and exhibiting elastic resistance to further extension. With the patient sitting and their knee flexed over the edge of the table, the patient then actively extends the knee while the examiner internally rotates the patient's tibia. Internal rotation of the tibia puts the tibial spine against the lateral surface of the medial femoral condyle, which is a classic site of osteochondritis dissecans. This is then repeated with a tibia and external rotation. A positive sign is exquisite pain with this motion at approximately 30 degrees of knee flexion when the tibia is in internal rotation, but then no pain when the tibia is in external rotation. The patient is standing on the test limb with their knee extended. The patient raises their heel from the floor through the range of motion of plantar flexion. For normal and good grades, the patient completes 4 to 5 times with good form and no apparent fatigue. For fair grade, the patient plantar flexes the ankle sufficiently to clear their heel from the floor. For poor and below, this is tested with the patient in a side-lying position. The patient sits with the test leg over the edge of the table. The examiner places their hands on the patient's leg approximately 6 inches inferior to the knee and compresses the tibia and fibula with the heels of both hands as if to bring them together and then releases. A positive sign is exquisite pain reproduction during the release portion of the test in the vicinity of the distal syndesmosis or ankle joint. The examiner palpates deep between the heads of the patient's gastrocnemius or forcibly dorsiflexes the patient's ankle when the knee is fully extended. With a positive sign, this elicits exquisite pain in the calf. The patient gets in a quadruped position on the table, and the examiner squeezes the calf. With a positive sign, there is an absence of ankle plantar flexion with this maneuver. Present but significantly reduced plantar flexion compared to the uninvolved ankle may represent a partial tear. The examiner activates a tuning fork and presses it on the suspected stress fracture site. With a positive sign, this elicits exquisite pain at the suspected stress fracture site. With the patient sitting, the examiner grasps the metatarsal head with their fingers and pushes it toward the calcaneus, causing axial loading. A positive sign is reproduction of the patient's symptoms. With the patient sitting, the examiner grasps 2 metatarsal heads between which is a suspected neuroma and moves the metatarsal heads back and forth while compressing them together. A positive sign is reproduction of the patient's symptoms of exquisite pain, burning, shooting, or tingling. With the patient supine, the examiner stands at the patient's feet and palpates the medial malleoli with their thumbs. The patient flexes their knees and then pushes off with their heels to lift the pelvis from the table. The patient returns their pelvis to the table, and the examiner passively extends the patient's knees and compares positions of the medial malleoli. A tape measure can then be used to measure from the anterior superior iliac spine to the distal portion of the medial malleolus. This is a maneuver used to ensure symmetry of the pelvis prior to measuring leg length. With the patient supine, the examiner holds the patient's foot under their arm for support and places one hand along the joint line and applies a medial force with the opposite hand. This is performed at 0 and 30 degrees of knee flexion. A positive sign is excessive medial gapping compared with the patient's uninvolved knee. With the patient supine, the examiner holds the patient's foot under their arm for support and places one hand along the joint line and applies a lateral force with the opposite hand. This is performed at 0 and 30 degrees of knee flexion. A positive sign has excessive lateral gapping compared with the patient's uninvolved knee. With the patient side lying, the examiner presses straight down on the exposed iliac crest. A positive sign is reproduction of the patient's symptoms of pressure or pain at the SI joint, but not in the lumbar spine.